next guest is Reed Tuckson. He's also an MD. And he also is an active member of the Institute of Medicine of the National Academy of Sciences. He's a member of the Committee on the Consequences of the Uninsured. And he currently serves as the board of directors for several national organizations, including the National Hispanic Medical Association, the Alliance for Health Reform, the American Telemedicine Association, the National Patient Advocate Foundation, among those that he serves on. He was featured on the cover of the February 2009 issue of Black Enterprise magazine and made one of the 100 most powerful executives in corporate America. So you want to know this guy. Dr. Reed Tuckson.
So let me sort of pick up a little bit where Eric left off about this revolution. There absolutely has to be the recruitment and the engagement of a whole new set of capabilities and competencies outside of healthcare. We are in deep trouble. Be very clear about America's health system. That being said, I am so excited by the possibilities, but I am not seduced by the technology. I keep my mind focused on what are we trying to achieve, what are our goals, and what are the challenges that we have to overcome. Technology for technology's sake is not exciting. What's exciting and interesting is how we are going to apply these things. We need greater precision and greater value in how we do at least three key things. Number one, how we are going to enhance the health of populations, how we're going to, number two, give people access to personally appropriate care that drives up quality and that takes costs out. And number three, ultimately, at the end of the day, probably the most important context is to manage the escalation in healthcare costs. Please understand that all of these conversations occur within a very clear reality. The escalation in healthcare costs has got to stop. What we heard from Eric is important because these are examples of things that at their fullest expression and intelligently used will help to decrease costs. But know this, the biggest cost drivers in healthcare today are unit cost escalation for devices, technologies, for labor, and for the use of places like hospitals. That's where the biggest drivers are that are causing America to have the extraordinary problem with cost escalation that we have. And by the way, even though we talk about cost escalation, it has almost become a cliche. You must understand how absolutely imperative it is that that be dealt with. This gives us a challenge for this meeting, but it also gives us an opportunity. The other place where costs are going up is because of utilization. And so we're going to have to be very clear about how we use technology, how we use it to obviate the need for medical interventions because we keep people healthier and not getting sick, and that we help them to not suffer from the complications of disease once it becomes manifesting. My point is this: discipline will be required under any rainbow, wonderful blue sky scenario about how these things get done. Discipline because somebody at the end of the day is going to pay the bill. Consumers will pay a lot of it because many of the things that you're here to talk about are going to be things that consumers themselves will purchase as a part of the normal process of living. What I love about the revolution in digital health is that I am integrating health things that used to be called sort of health just as a normal function of my life, my apps, my mobile apps, the way I engage my iPad and my smartphone. There are things that I'm doing just in the process of living that don't have to do with reimbursement for medical care services. But at the end of the day, I am still paying for them. The amount of money that consumers are paying for health and the availability of discretionary resources are significant. And so you've got to be very clear that at the end of the day, somebody is paying, even if it is the consumer, but as these things roll into the delivery system, somebody else's dime is involved. And there is no more room in the cost curve to accommodate things that don't add value. So there is a discipline. I worry when I say that, because the last thing that I want to do is to put a heavy-duty burden of value proposition that stifles innovation, that diminishes the flow of venture capital dollars into these sorts of innovations. So there is a balance, and we have to be very clear. Let me just quickly, in the last couple seconds, as we just sort of helping to set up some of the conversation, I tell you where I'm really focused. I'm very much focused on this notion of prevention of disease. I hope you do realize the level of tragedy that is befalling this nation. A tsunami of preventable chronic illness washing over a delivery system that is already unaffordable for most Americans. The number of people who are obese, there's not one state in America where they are less than 20% of its population that are obese. Now 27.5% of Americans are obese. We are headed to 43% by 2018. Just imagine what that means in terms of the magnitude of disease and the economics involved. Diabetes, I hope that we don't have to have all these people using Eric's new device. 8.7% of the population is diabetic. That's up from 8.3. The numbers are moving. We will be at 1 out of 5 conservatively diabetic by 2020. Frightening realities. You can either solve it on the front end, or we can pay for the apps and the interventions around monitoring glucose and all the drugs and so forth and so on. So we've got to deal with that, which means we need to have this information that allows us to understand who is at risk early and then be able to intervene. Personally or individually available, what is the level of risk for each individual? Now we have a lot of data now that helps us to identify who is at risk, and more data to come. The question that has been asked is, who should have access to that data, and why? And so the issue of trust becomes essential. This whole field is going to be balanced precariously on the pendulum of trust. And therefore there is an ethic to what we are doing in this room and at this meeting that must be highly attended to. Clinical decisions are second, and I think a lot about those very importantly. This revolution that Greg has described, and congratulations to them and what they have done, the amount of data and information that he is going to now make available on top of all the other data is a huge cognitive challenge. Our brains are the same size as they've always been, except for a few of you. The number of facts per decision that a physician must make, and now a patient engaged with a physician must make, are extraordinary. It used to be we would only have information in terms of facts about me as a physical structure. Then all of a sudden we had information about me in terms of the basics of genetics. Then it was functional genetics. And now it's proteomics. The curve of information is extraordinary. Nobody is smart enough to figure out how to use all that and process it. So the actionable intelligence, the point of care decision-making digitalization revolution is going to be huge. So I'll just leave those as sort of two things. I've got a few others that I hope that we can get to in the conversation. But what I sort of summarized, ending exactly in 5 minutes, Mr. Moderator, is let's be very excited. I am a total fanatical cheerleader for this movement. But if we are not focused on what we are trying to achieve, the goals of these things, how they will integrate with other pieces to be able to make sense out of, to solve a problem, to move us forward. And if this movement, this revolution, is going to give us information that we do not know what to do with, that we go chasing after zebras running all over the landscape. Oh, I got to have this diagnostic test to check to see whether I got this because my profile indicated that I may be at high risk with a statistical probability of such and so that I may have that. So I got to get this nuclear imaging procedure and this engagement and this lab test. All of a sudden, we just took a healthcare system that America cannot pay for anymore, and we just put it on steroids. That is a moral, horrendous conundrum. One that we cannot allow happen, and yet, as I say that and sit down, I will come back to, whatever I do, don't let me say something that stifles innovation.
Very nice. Can you hear me? Am I? No.
let's pick up with that theme because you got a little agitated, I know. A little excited.
I'm sorry.
You're passionate.
That's his style.
You're passionate about the problem because you obviously see this as a great problem. And this flood of data, what do we do with it? For example, like you were mentioning all these different tests at the end. Are physicians going to feel threatened that their patients know all about these tests and things, and they're going to try to second guess and what their prescriptions are, or what kind of diagnosis they are? If the data is available to them, they take it home, they look at it, or they can become junior doctors. Doctors feel threatened by it.
Speaking of books, I just wrote a book called The Doctor in the Mirror. It's just will be out in your bookstores shortly. But the thesis of the book is look in the mirror and you'll see the best doctor you ever meet. And it's basically trying to, again, re-emphasize this notion of empowerment. There's no question that the thesis of your point is that the traditional confines of the patient-physician relationship are undergoing a profound change. And so the balance of power has certainly shifted. The physician always had the power because they had the knowledge, the information, and the patient had nothing. Now the patient has equal egalitarian access to information, probably has more information about their particular rare disease than the physician does. However, that's a good thing. The challenge is the patient is going to have an awful lot of struggle trying to make sense of it. They will certainly need to understand it, what they can do to implement it, but also understand it in terms of their own values, needs, and preferences, which is fundamental. But at the end of the day, there are tough choices that need to be made, and they're going to need some counsel and guidance. The physician will have a hard time. The other place where this is, though, I think the most challenging, is the physician is being bombarded with a lot of data, too. They're getting a lot of data from delivery systems, feedback from mobile app data will be coming. They're getting a ton of stuff. And the question will be is now most doctors don't even have the most rudimentary of electronic medical record systems. And so now we're going to have to figure out what is a value proposition with enough of a return on investment to get physicians to buy into electronic systems that will allow them to analyze data and be able to organize it and then feed it back into an intelligent conversation with the patient. We are a long way from figuring out how to make that link come together.
Eric, you were shaking your head on all these.
Well, I think one key point we have to recognize is that, and you touched on it, Ira, that the access to the data. So currently, the medical profession, at least as represented by the AMA is lobbying the government hard that the public should not have access to their DNA data. They shouldn't have access because they wouldn't know what to do with it, and that it's dangerous and it has to be mediated through a physician. While at the same time, there have been surveys done of physicians, tens of thousands of physicians, and it's shown that 90% of physicians don't feel comfortable dealing with genomic data in terms of helping their patients. So I like the doctor in the mirror concept, because when the internet was started in the 90s, it was sort of thinking about empowerment of information, and there wasn't the information. Now, with sequencing, and it's that person's DNA. Who could be more invested in the ability to prevent conditions, which I couldn't agree more. That's where we have to shift to. We're not dealing so much with the chronic disease burden, which absorbs more than 3/4 of the healthcare budget. So I think that part of our problem is we don't have, as a medical profession, we have not let go. And we're still having one of the major lobbying forces to try to hold back the data from the people that deserve. It's their data. They should have it.
I think there are 2 points here. One is about the power of the doctor versus the power of the patient in this equation, and then the other is this policy issue of our healthcare system in the United States is fee-for-service. And so to the extent that that's going to always be there, we will drive ever more services to be used. We've had interesting experience at Life Technologies. We have thousands of employees in the United States, and so we went to this Safeway plan a few years ago. Consumer-driven healthcare plan that basically tried to turn that model of fee-for-service on its head, gave our employees a sum of money and said, now go do your healthcare. And then obviously put in a ceiling for catastrophic care when needed. And the change in psychology of our employees over the last few years has been amazing. Because now they have precious dollars. They'll decide where they want to spend it in terms of what technology could make a difference. And I think this is a model that at least should be considered more and more because it puts the power back in the patient versus this whole dialogue of should they have access to the data or not. It's insane. It's their data. It's their journey. It's their outcome they should be responsible for and obviously have to they have the most vested interest in what happens here.
So you're basically saying that we have to look in the mirror again and become our own physicians, so we know how to spend. If we're given a pool of money, we have to figure out how to spend it. Do you think most Americans, Doctor, do you think most Americans can do that? They can figure out how to ration their own health care and where to get it and decide how to use it?
One of the things I learned is a fundamental principle. I used to be a jazz musician and played fairly aggressive jazz. Never talk down to the people. People are much smarter than we think they are. And so I have enormous confidence in folks. Having said that, it would be terribly unfair to the American people to turn them loose on this great frontier of a world unsupported by either new kinds of education or access to coaching. And they're going to need that. I think one of the great challenges that is raised by what Greg is doing is genetic counseling. People are going to have to make some very tough choices about their health and intervening on their health based on probabilities. Ira, you spend a lot of time, and you're much more smarter than I am about the quality of science education in America's high schools. But I have a suspicion that Americans are not well trained on understanding probabilities and are not well trained to be prepared to make fundamental decisions like whether I get a prophylactic breast mastectomy based upon a probability of such and such amount that I may get breast cancer. Those are tough choices. And so one of the things that I think, if, as an entrepreneur in the audience, we will need to be thinking about is how can we solve for the ability to provide cost-effective access to people that kind of information that allows them to become learned, to become literate, to become smart, and make those kind of choices. And I think that because I know that as Eric's thesis in his first comments were that if you leave it to the medical care system to figure it out, we'll never do it. We need to call in the Army. And the Army is at CES. And the Army understands how to use consumer-friendly, social network-oriented technology to be able to help move people from point A to point B. We're going to need all of that if we're going to have any chance to be successful in what Greg has done.
You're saying that crowdsourcing a problem might be a solution.
Well, yeah, there's already evidence for that. There's people's lives were saved. They're just posting their condition and picture on Facebook. So we already have evidence that crowdsourcing through lay people, and all that's through interactions with the medical environment. So, but participatory. I mean, that's the key. We don't have that now. Except for
tell me what you mean in detail.
Well, what we have now is we have all these advertisements for a drug. Ask the doctor, right? And that works really well. That's an incredible investment. We have more men with erectile dysfunction now. It works really well. So the point is that when you get a person participating and saying, like a perfect example, which is wrong in our country right now, a drug Tegretol. Tegretol is a widely prescribed medicine for various things like neuropathy and migraine and whatnot. And in Taiwan, you can't get a Tegretol prescription without having a genotype to be sure you're not going to die with Stevens-Johnson syndrome. Now, the incidence that is low, 1 in 10,000. But you know what? There's hundreds of thousands of people getting new prescriptions of this drug. In this country, there is no genotype for that drug. So I had a colleague of mine whose wife almost did die in the hospital because she got Tegretol for trigeminal neuralgia, and then she was in intensive care unit, and she didn't get the genotype, which should be available. So why shouldn't, as an example of participation, the doctors aren't doing it. They don't feel comfortable with genomics. You get a prescription for Tegretol, say, gee, I better get this checked because I don't want to take this risk. And that's the kind of example of participation that we need to have in our daily practice of medicine.
I think you touched. Go ahead.
No, I'm in total agreement with this, but you also have to come back then to the incentives of what will make the patient want to participate much more actively in seeking out these answers and being a much more vigorous participant in their own health. And again, if healthcare is essentially free, then you're never going to fully engage. And I think that is one of the underlying issues as well.
So when could healthcare ever be free?
It is free.
It is?
Most employers, let's stay on the employer side.
Yeah.
Most employers haven't moved to a program that we have done. And I'm not advocating that. I'm just simply saying there's a change in psychology when you have to see what actually is being spent for your health care, and there are limits to how much could be spent for you. It changes how you think about it.
I think what Greg is getting at, and I think he's on to something important, is what he's saying is that for still most Americans do not suffer personally for the financial consequences of the health choices that they make or the choices that they don't make. So that as they become sickened and ill from preventable illness and need to interact with a very expensive medical care system, they're not paying the bill. There's no financial incentive. And so what Greg is, I think, getting at is, and we certainly agree, we sell a lot of these products, and we're seeing the biggest uptake in all the things that we do on our insurance side of our business has been the uptake on the kind of products that your company is buying. But what I think is critical to what Greg is getting at is he's talking about aligning incentives. So instead of having a war between patients and the people and their employers who pay for their care, a war between patients and physicians as they battle each other out, what we're sort of trying to figure out is how can everybody sort of be aligned in the same way. So patients now have what's called skin in the game financially. That's saying the choices that I make, if I decide to go to a physician or a hospital that is not very good and I have bad outcomes, and we knew that they weren't very good, then I have to be involved in that decision. I have an incentive. If I know that I have risk factors for diabetes and I don't change my behavior, then I won't get a benefit on my, as a cheaper insurance product. So we're having that. But what's also important is the physicians who are caring for those people are now being moved off of Eric's, which he doesn't like correctly, fee-for-service, moving into what's called an accountable model, where you are now accountable for the quality of outcomes and the financial performance of how you treat a population of people. What that means in a nutshell and very succinctly is that there is an incentive for the delivery system to identify patients who may be sick early, keep them from becoming ill, which is the same incentive that the patient has for their benefit design, and now you're starting to find a new paradigm in healthcare where you're aligning everybody's financial incentives, and then the notion is how can you support that with new tools, new capabilities, which come from the digital health revolution.
Let me just turn that situation around a little bit, and because I agree with you on the point you made before about trust being very, very important. Trusting the whole system. You talk about diagnosing early and prevention. What about people who say, I now can look at my human genome and I can see on it that maybe I'm susceptible to diabetes, I'm susceptible to some health disease, and my insurance company is looking at the same data and is going to say, I'm not insuring you now. So somewhere down the line, you're going to come down with this service, and I'm going to put you in a room full of people who are high risk. And people are afraid of that, and it's a matter of trust.
No, there's no question about it. I was fortunate enough a few years ago, for several years, to chair the Secretary of Health's Advisory Committee on Genetics, Health, and Society. Our number one as a group, and my number one personal agenda, was to make sure that we did everything we could to pass legislation for non-discrimination for genetics. We have pretty good legislation, and so I would say to you that there is legislation that prevents that kind of behavior. Every one of us has, when you get down to the genomics that you've described, Greg, a pre-existing condition for something. And so there's good legislation that needs to be continually revisited and enforced. So at the end of the day, that sense of trust was absolutely important, and I think we've attended to it, but of course we need to be ever vigilant about it.
All right, let me about to go a phone number because I'm so used to it. I don't have a phone number. Step up to the mic. We have some questions. We have some time to take questions. So what's the first step? You talked about the healthcare system is ossified. You talked about it. We need huge changes. Is there a roadmap?
We have a model. I mean, the model that Reed described about an accountable care organization, which is going to take a long time the way it's mapped out with the current administration. Kaiser, come around. They're into prevention. They've got great electronic health records. They want to they digitize everything. They want to get into genomics. That's a pre-existing model that works. It's not fee for service. They get away from doing tests and procedures for unclear purposes. And so we've seen it work.
You know, there is one roadmap actually that people might find interesting. and we've had it for 10 years. It's called, and I would urge you to go back in your search engine and pull up something called Crossing the Quality Chasm. The Crossing the Quality Chasm report comes out of the Institute of Medicine of the National Academy of Sciences, and it basically is a roadmap for the redesign of the American healthcare system. What is so frustrating when you go back and you look at that report is how little we've come down the road. But it predicts and describes almost everything we talked about. The need for patients to have access to their information, the need for free flow of information between two patients and between patients and their physician, the need to respect a patient's values, needs, and preferences, the need for healthcare to be outside of a face-to-face setting and to occur in non-traditional environments 24 hours a day, 7 days a week. It describes